Okay, I'm gonna go ahead and start talking to you about PIER surgery, which is porous implant ear reconstruction. So first, I have to thank someone that didn't get thanked earlier in the day, but my family, my husband John, my son Jeffrey, and my daughter Casey have been at every single Earicles event. They work the events, as you may have noticed, and help wherever help is needed, and really honestly have been my biggest supporters, because there's clearly some sacrifice that goes along with being a surgeon that does really long operations many days of the week, and they really, that's what allows me to have the career and profession that I've chosen, and so thanks you guys. So I'd like to tell you a little bit about myself, because my path to medicine was a bit circuitous. It was not an intentional thing that I thought I wanted to do, so I'll tell you sort of quickly my history. I was born and raised right here in Southern California and stayed here until I went up to college at UC Berkeley. Didn't really know what I wanted to do, had a father that was an architect and a mother that was a nurse, and lo and behold, I ended up falling in love with architecture in college. And for me, it was design, visual, understanding of things, creating something. The creativity was huge for me. And so I did my whole 4 years in architecture, but when I got to the end in discussions with my husband, I wasn't sure that this was exactly what I wanted to do with the rest of my life. So I just switched gears, and I ended up moving across the bay, and I went to medical school at Stanford, and it was there that I sort of a little bit longed for the creativity of architecture. So what happened is I encountered my first surgery for a cleft lip repair, which all of a sudden it hit me like, this is art. This is sculpture, just sculpture on something that's living, and incredibly challenging in my eyes, and something I really loved. So from that point, I was sure what I wanted to do, which was train as a plastic surgeon at USC, and then go on to do a fellowship in what we call craniofacial surgery at Children's Hospital Los Angeles. And that's when I discovered what Microtia was and how it was treated. And again, it was sort of serendipity. I never planned a career in ear making per se, but I fell in love with that as well, and particularly fell in love with my patients. And so I worked at local children's hospitals in Los Angeles in different capacities, and ultimately in 2012, I went into private practice where I could focus my whole career on ear reconstruction. So there is something really fascinating about ears, and if you don't know anybody or have someone you love in your family who has any issue with an ear, you don't really think about ears. But I read an article on the psychology of protruding ears, and the quote is, "Humans visually understand when facial features appear in balance, and few, if any, features elicit such negative responses at ears that are prominent, overly large, or misshapen." So overly large ears is not particularly of concern in this room, but it is something in my career, but it brings up this point that I think is really important. So when you look at this picture and you focus on this child, you do kind of see these ears that they're actually not large ears. They're normal sized ears. They're prominent in that they're just rotated too forward, but it draws your eyes. So when I took her to surgery to do a minor adjustment to put her ears back into a normal position, everything changes. And what changes is you focus on her face and you don't focus on her ears anymore. And to me, like my whole goal every day I go to the OR is I want an ear that nobody notices, because then you kind of made it. So when I'm trying to think about what am I going to say as a Microtia surgeon to all of you out here in the audience, I'm trying, as a mom, to put myself in your shoes and try to think, well, what would I most want to hear from somebody who does this pretty much on a daily basis? And there's just a baby's born with Microtia, and it's just endless questions. Is my child going to grow up to be, quote, normal? Are they going to hear? Are they going to adjust? Are they going to have friends? Are they going to have a career? You go through all the craziness. And so we're going to try to just do a talk answering questions. First of all, the most common questions that parents ask me, but then I'll lay on top of that the questions that I believe you should ask of your surgeon. So we'll start simple and quick. Microtia means small ear, and atresia means no ear canal. And when you look at this line of pictures, you can see there's this great variability. And I think by now everybody's seen this image of our grading system, which is just convenient for use. But yesterday in patient appointments, I saw every single one of these and every combination of them. This is not representative of Microtia in general, because I'd say about 80% or so are going to be grade 3 patients, many of them. But we certainly see all grades. So what causes Microtia is unknown. There is clearly some component of genetics and some component of the environment, and we're not sure what is contributing to what. But these are 2 patients. The little girl is one of my patients who had a porous implant surgery in 2014, and she's snuggling with her grandfather, who actually had an ear made by Dr. Bert Brandt very, very early in his career, 30 years before I did his granddaughter's ear. And so clearly in this family from Ecuador, there is genetic preponderance. And Ecuador happens to be one of the countries that has the highest incidence of Microtia atresia. But in most cases, we do not know what causes Microtia. This little baby is now a hip-hop dancer, Tiffany Wilkie's son. But he has bilateral Microtia atresia, and there was no family history of this and no understanding of why this occurred, and other conditions can occur with it. But I'm going to just make this point again, because you guys in the audience can't hear this enough. We all have this, those of us that have kids, this guilt. I mean, it starts almost before the baby's born, but when the baby's born and there is an issue, we feel this tremendous guilt. And we as surgeons who live in this world want to make this statement that if you hear nothing else today, we want you to understand you did nothing to cause this for your child. You just didn't. So you need to just get rid of all those feelings of guilt and move on to the rest of the talk, where we're going to help you figure out ideas for what to do. So this is a kind of an odd question. How does one create an ear? And you have to think about what you're making, and that it's really important to understand ears are not all the same. You can't construct them all to be the same, because everybody's sort of got a different ear. Obviously, if you're bilateral, it's a little bit different. But for unilateral patients, one-sided Microtia, you're matching something. And when I saw this, like, this is an ear. This is ear cartilage, what we call an anatomic illustration. It's way more complicated than anyone would imagine, the three-dimensionality. And this is why it's extremely challenging to make these ears. All these little things have some bit of a purpose, and if you don't have a big collection of them working together, it doesn't really look like an ear, and then it gets noticed as opposed to not noticed. So there really is an argument to this. In the world of plastic surgery, creating ears is accepted as one of the most challenging operations that we do. So I just want you to think briefly, what are the essential ingredients, for lack of a better word, to make an ear appear realistic? And there's sort of 5 things that you need. You need a helical rim, this outside portion. The green is called the anti-helix, and it forms this Y shape. The bowl, it has to be deep, and it has to be large enough to match the other side. The tragus is sort of tricky. It's 3-dimensionally floating in space and covers the front of your canal, and then your earlobe. So we've all sort of aware of these options for treating Microtia. Certainly, you don't have to treat Microtia or atresia. As long as it's unilateral, that is an option. A prosthetic ear can either be an adhesive, so non-surgical option, or it can be a surgical option where we drill either a magnet or a clip into the skull, and then that prosthesis clips on. Then there's rib cartilage reconstruction and porous implant ear reconstruction, or PIER, and those are obviously the bulk of the surgical treatment. So as a surgeon doing this, I tried to put together a list of what I want to achieve, what my goals are for my patients. And I came up with this list, and it's an ideal list. So you want an ear to look natural and realistic and symmetric. You certainly want it to be safe and long-lasting, lasting a lifetime. Ideally, if you could, you'd like to do one outpatient surgery and do it really young in life and have the least pain possible. And then the last thing, one that's somewhat overlooked, is you would like to do a surgery that as technology improves, you can adapt to that new technology, or have that in mind. And we'll talk about that a little more. But this is the opinion part. It's my opinion that at least in my hands, I can do this best with a PIER surgery, porous implant ear reconstruction. So the rest of the talk is going to try to explain why, I guess. So what is PIER? This talk used to be called MedPOR, ear reconstruction, and MedPOR is the name that you still hear very frequently. But I changed the name because I no longer use MedPOR very often, a little bit, but I'd say 90% of what I use is an alternative product called SuPor, made of the same material. But at any rate, in its basic form, you create this implant to look like the other ear, and you cover it with natural tissue from the patient and their own skin. So critics of this method, of which there are many out there because it's not a common method, it's not done in most of the world, their response is, well, why would you ever put something that in your body that isn't natural? And my answer would be because sometimes maybe that's the best solution, and we have evidence for that in many areas of medicine. So even though we know how to make a breast when one loses a breast to cancer from natural tissues, you know, there's pros and cons to all these things, and now more women are choosing breast implant reconstruction over their own tissue. Similarly, there's, you know, over 1 million total hip and total knee replacements. That's a foreign substance that you're putting in your body, but it's a good solution when your natural knees don't work. We don't know how to make a knee or a hip without using a foreign substance. Then, of course, we know about cochlear implants, bone-anchored implants, and then you even heard that there can be porous implants used for a portion of rib cartilage ear reconstruction. So we don't have an ideal, and the reason we don't is because that very complicated cartilaginous shape that you see in the drawing, it's thin and flexible. Ears are kind of amazing that you can like bend them over like this and they just pop right back into position, and in the world today, we haven't figured out how to do just that. So the porous implant can be very thin, similarly thin, but it is not flexible. It is hard, like rock hard. Rib cartilage has to be thicker because of the substance that it's made of, and it's minimally flexible. It's more flexible than a porous implant, not flexible the way our own ears are. So what exactly is a porous implant? It is a high-density porous polyethylene. That's the name we give it, and this is a close-up view of what that porous structure looks like. It's been around for a long time, actually, since the 70s, and used commercially since the 80s. And the pores, or holes, make the implant very light because it's 50% air. And interestingly, of all the materials, foreign materials you could put in a body, the FDA has deemed porous polyethylene the least reactive. And it's got a very long track record of success, more than 35 years that the porous form has been used all over. These are examples of craniofacial surgical applications of orbits, noses, jaws, zygoma, or cheekbones. But as far as this porous nature, what's really critical, probably the most important thing about this substance and why we've been using it for so long, is those little holes are specifically designed to the right size, like 100 microns, to allow your body's tissue to grow into it. And I've seen this in actuality in the operating room. If you cut an implant that's been in someone's body, and open it, not that you're gonna do that, but if you did, it bleeds inside, and that's because the body's tissue is integrated. It's not something we're guessing at. We've proven it with studies. So even though this material can be made very, very thin, it's still extremely strong, the nature of it. However, it's not easy to work with. I'm the very first person to admit that. It really must be covered exactly perfectly 100% with your own tissues, or it won't work. So implants that aren't porous have a completely different reaction in the body. So this is a breast implant before it's been implanted, and then the second photo, a breast implant with a capsule that's formed around it, and that's what our body does. This is foreign. I'm gonna wall it off so it doesn't attack the rest of my body. And surgeons have to go in and release these capsules because they cause deformities, and you can see that that's called a foreign body reaction. But you won't find that happening with these porous implants. So you really have to go all the way back to 1982, and Dr. Alexander Berghaus kindly shared these pictures with me of the very first patient known to get one of these ear reconstructions. Obviously, technique was done very differently, and we've learned a great deal, but this is the first patient. And then MedPOR came to America in 1991, was the first time that was used, and there was a lot of issues in those early days of using MedPOR. There were high complication rates. We hadn't figured out how to use it properly. We weren't covering it 100%, so there were a lot of exposures, and the technique was quite challenging. So that led to a feeling of, this is just not a good technique. But rather than say that, it's nice to problem solve. This is an example. This is my patient, a little girl who had the first SuPor ear reconstruction, which I did back about almost 2.5 years ago. She only had one operation, that's all she needed, and she got a complete ear. So what is SuPor, and how does it compare to MedPOR? I'd like to spend a little bit of time going over that. They are the exact same material, this porous polyethylene. The implants today have the same basic shape as well. SuPor has been deemed by the FDA just as safe and effective as MedPOR, and it turns out that the developers of SuPor were the developers of MedPOR as well. Broke off, formed their own company, have a different manufacturing process, and there are differences as well between the two products that I've found, and I've worked very extensively with SuPor. It's, at least the rim is more flexible than the MedPOR rim, and the base is easier to carve because of how the manufacturing is done, and I believe that you can better shape the ear with a SuPor implant in my hands than with the MedPOR implant. That implant has been in use for a long, long time. So here's a little video just showing the basic differences. There are several companies that are making the porous polyethylene implant. This is the SuPor implant here, the rim and the base, and this is the MedPOR implant here, the same components, and you can see they look very, very similar. This top piece is a little longer than the one on the MedPOR, but that's not very significant. And on the other side, they're very, very similar in appearance, just some minor differences. In addition, what you might notice though is the SuPor rim is very flexible. You can twist it completely, and it can hold a shape and be manipulated so that I can create and sculpt essentially this rim. The MedPOR implant, although can twist, is restricted, and if I twist more, it might fracture. And its ability to squish this way, I'm hitting big resistance when I do this, whereas this, you can completely twist it, and it just bounces right. So the next thing to discuss is, now there's these two types of surgeries we understand, so what are the differences between a rib graft type of surgery and PIER surgery? So first, they also have some similarities, and that would be in the skin that covers the ear. We call this circled area of skin like gold because it's the proper color for an ear, and it's all that you want on the front of your ear reconstruction if possible. But then you won't have enough to cover the back in either technique, and so you get the back skin from other places, sometimes an arm, sometimes a groin. Also now for the differences though, clearly the material is different, one being synthetic and one being natural. And then the appearance of the framework at the first surgery also has to be different. That's because the techniques are quite different. So the PIER is built three-dimensionally and very thin, and it's built to mimic the normal projection on the other side right at that first surgery. The rib cartilage uses a different technique, so it is built a little more two-dimensional, and because of what the body does with scar tissue, you can't make a rib ear as thin as your ear, or it would just disappear. The body would kind of just swallow it. So you have to make some structural strength by making it a little bit thicker. So then what covers the implant? It's a little bit different in the two techniques. So the implant is covered with what we call a flap, which I'm going to spend a little time describing because it's a little tricky concept, but it's your body's own natural tissue. And what we do is it covers it completely, and then we put some suction on it. And if you look at that center box, when the suction applies, that's when you get the shape of the ear. Then that's covered with skin grafts. This is an ear reconstruction by a very well-known surgeon in Canada, actually, Dr. Leila Kasre, and her video shows how the rib cartilage is covered. They make a pocket in the same position, obviously, where your ear should go, and they slip in this implant that they've created from rib cartilage. And then when they're done, they put it on suction as well, and you see the form of the rib. So the timing is a little different between the two surgeries. PIER can be done as young as 3 years or as old as anybody healthy enough in their 50s or 60s. Rib cartilage, depending on the surgeon, starts between 6 to 10 years of age, a little bit dependent on how large the child's rib cage is. There's a little difference between the number of surgeries. Usually, PIER will require 1 surgery, but in some cases we'll need a second surgery or small revision. Rib cartilage is 2 to 4 surgeries depending on the technique. In terms of longevity, rib cartilage has a big head start on PIER because that's been done for 58 years and we're at 26 years, but both have been around a long time. This is a question I get from parents a lot of the time. These PIER surgeries, these ears don't grow, so you have to make them what you envision the adult size is going to be on the other ear. And fortunately, people have studied that for many, many years, and we sort of know if you're 3 years old, you're going to about 80% done growing, and if you're 7, you're about 90%. So we can judge what size to make the new ear. So exactly how is it created in terms of these implants? There's a couple little videos to show you. So this is the SuPor implant. We call this the helical rim and the anti-helical base. And these two pieces are soldered together. What I like about this SuPor implant is this rim is extremely flexible. And for instance, in the case of the mother's ear of this patient, she's got a very tall and thin ear, and we can literally change the shape of the helical rim to exactly match the mother's ear if we were making that today. But for this daughter's ear, she has a wider, rounder ear, and we can change the implant rim to mimic that shape, although we will make it larger because she's only 4 and we need to grow this to an adult size for what we put in permanently. So here's the rim and the base held together with a clamp, and then we use a cautery pen to solder these two pieces together. When we're completely done with this implant, it will look as though it's one piece. Here you can see our completed implant, which is made quite detailed and actually quite thin. And it is a one-piece implant. It's solid in that it doesn't have any flexibility anymore, except that the rim is a little bit flexible. So I would like to go over a little bit of the steps that are used to perform this type of operation. So I'll introduce you to Thomas, who is an adorable mohawk supporting little guy who has a grade 3 microtia, and we're going to talk a little bit about some changes in the technique for this surgery. So the first thing we're going to do is look at his normal-sided left ear, and we're going to apply what we learned about how ears grow to make an adult-sized ear, and then we're going to flip that shape to the other side and be able to figure out where to position this ear so that it's symmetric. Once we've figured that out, we need to analyze his anatomy. So he happened to be shaved, but we don't shave kids normally to do this analysis, but it made for a great example patient. So I can feel, just with my fingers, his arteries, and then I can use an ultrasound little Doppler to get the position of his veins, and this sort of maps out the blood supply to the tissue that I'm going to use for this flap. What is this flap? So it's a living membrane of tissue that lies between the scalp out here and your skull bone, and we call it fascia. And, you know, hands down, this is the most critical part of surgery. If you don't do this flap perfectly, you will have problems. This is why it's an ornery operation. I'm the first to admit that. The converse is true, though. If you do the flap perfectly, you'll have a really nice ear. So this is just a cross-section of your head, just above your ear, right here in this black box. And if you look at those layers going from skin and fat on this side, muscle and bone on that side, in between those lives this special tissue that we call the fascial flap, or sometimes TPF. This is what it really looks like. I'm sorry, a little bit of gory things coming your way, but really it's so thin and delicate, especially in a younger child, that it's translucent. You can see arteries and pulsing and veins, etc. And so my right hand, Tiffany, came to the OR one day and saw me put this up, and she goes, she's got 3 boys, by the way. She goes, "Oh my God, it looks just like a fruit roll-up." So I thought I'd throw that out for her. It's odd, but it is important to have analogies. So the key to success in porous implant ear reconstruction is this living membrane flap. And we talked about this. If it's done right, you'll have a healthy and stable ear. So this is a question a lot of parents ask, like, well, if you're taking this flap away from the head, does it grow back? No, it does not grow back. So what does that mean? I sort of make an analogy to your appendix. We're all born with one. Some of us lose them. They don't really do much for us. And when they're gone, we don't really miss them. So that's sort of true with this. There are some short-term differences like sensation changes and things like that. But basically, over time, you don't really remember you're missing this tissue. So I've changed a little bit of the design of the flap. Traditionally, the way I was taught, the flap was sort of always done like this, following this one artery that runs towards your eyebrow. But when I mapped out the arteries and veins, it dawned on me that this flap, this traditional flap, only has 2 arteries and 1 vein. And if it's so critical, if this is the most critical part of the case, I should give this flap every chance for success. So maybe there's a better way to do that design. And if I just move over, then you'll notice that on this particular patient, different in each patient, there's 3 arteries and 2 veins, and that certainly seems like a better way to go. So in this little guy, that's what we did. So the next question is, if you're dissecting all the way up to the top of the head, how on earth do you move the flap from up here to down here? So in my fellowship training, this is how we did it. We made a 10, 12, 14 centimeter incision along the scalp. In a girl, maybe not such a big deal, but in a boy who wears their hair short like this, it actually is a big deal. They all lose hair in that area. You can't really prevent that. So when I finished fellowship, I really thought about this problem long and hard and felt like there was probably a better way. And so in 2006, I did this child's ear, and he was the first patient, to my knowledge, ever to have that flap harvested without any scalp scars. Took me a little while to figure it out, but we haven't turned back, and we've gone on to teach others how to do this technique, and I guess I feel like to date, this is probably one of the things I'm most proud of to have contributed to Microtia surgery. So we get this flap out through this small incision behind the ear, and then we bring in our implant that we constructed, and we're gonna cover this implant with the fascia as we talked about, and here's our little guy, and we're gonna... So now we've completed covering the implant with the flap, and we're now at the point where we're gonna put suction with this drain on, and so when we do that, you'll notice that the ear will gain a little more definition, and it takes the form of the implant. So that drain is only used in the OR. It's removed at the end of surgery. Well, once the dressing's on, we don't have drains. So kids don't wake up with any drains in this procedure. So now we're gonna harvest skin from the upper arm. We take it from the inside portion so that the scar, after we remove the skin, we close it all together, and it forms one line that when his arm is down again, you wouldn't see it from. So that's the skin, at least in boys, certain boys, where you don't want hair growth, so you don't go to the groin. In my case, I don't like to go to the groin in boys. We use that to cover the back of the ear. And then we use that ear skin that we like the color of to cover the front. So here's this little guy at the end of his case. Might have been Dr. D who helped this little kiddo. And so what's the recovery time? Well, this is like seconds after arriving. He hasn't really even opened his eyes yet, but he was hungry, so.
There you go. Is it yummy? Yeah.
Oh. That was Dr. D's voice. Yes, it was her. How did I know? So 1 hour after surgery, you get to go home. You don't spend any time in a hospital, which is great. Even if you're done at the main hospital for apnea or some other reason, you still almost always go home. There's minimal pain. There's not like screaming pain, and we have pain medications if needed, but it's not like a very painful surgery. US patients will stay in LA for 2 weeks. If you don't live in the United States, you stay in LA for 4 weeks. And you know, you do get back to life pretty quickly, especially like these younger kids bounce back super quickly. You'll hear from an adult who maybe didn't bounce back to go to Disneyland 6 days after getting the ear made, but this little guy did. And here you can see him the first time he sees his ear with me on 1 week after surgery. So we got some really cool people in the operating room, and these folks go all out for your kids. They get ultra customized cups, whatever they want. And we've had super creative patients, and literally, like if you can Google image it, you will get it on your cup. Now, also, in a very cool way, after about 6 months, you can go back to your normal life. You are not restricted. Everybody does sports. We have some highly, highly competitive athletes in football, hockey. Oh, I messed up. 6 weeks. Sorry, thank you, boss. Okay. 6 weeks, you're back to everything. And speaking of competitive athletes, about 3 weeks ago, we did this gentleman's ear. He is 20. How cool is that? He is going to the World Games for power tumbling in 7 weeks. He's got 1 week of practice. Intensely cool. All right, this is our little guy, Thomas, and here he is at 7 weeks, so back to his normal life right then. So how long does it really take to heal, Dr. Lewin? Like, that's what we want to know. When is it going to look like it's going to look? So I had a super awesomely compulsive dad who sent me pictures every single week of an ear in the same position so I can show you how ears heal. And it was really great. So here's week 1 when the ear is swollen. It can be any color at this time, pink, purple, crazy colors, and swollen as you see. And then by 2 weeks, the blood is flowing to the skin and it's starting to a little bit change color, still obviously very swollen. And then we just go week by week and you start to see how this flap changes, how the skin changes, how the colors differ over time. And then here's 2 months out and the scars are still present, but they're fading, still a little red even at 3 months after surgery. And here she is at 6 months and she's pretty much what she's going to be. I don't think she's going to change significantly. She's wearing her glasses, pink glasses. So I'll show you her. She is adorable. This is Lauren. She's before and 6 months after surgery. I love compulsive photographer families, just it's out there. So here she is from what the view I really like, we call a worm's eye view, where the only view where you can see both ears at the same time and really, really gauge symmetry. And then here she is, and her ear probably measures a little bit bigger because she's 3 and her other ear's going to grow a little bit more. So this is pretty cute. 3-year-olds are super honest and super cute. So one of my kids from our Washington, D.C. Patient panel is going to talk to you about what do these ears really feel like.
Okay.
Aaliyah, how old are you?
3.
You're 3, and did you have a big ear made?
Yeah.
Where? Where is your big ear? Over there. Oh, I see. Can I ask you a question?
Yeah.
Does it ever hurt, your big ear
No.
that I made for you?
No.
Do you ever sleep on your new big ear?
Yeah.
And does it hurt when you sleep on it?
No.
No, not at all?
No.
Okay. Are you able to move your ear? Can I see? Now come over here a little bit. Let's see. If we go like that, I'm gonna move your ear. You tell me, does it hurt when I move your ear?
No.
That doesn't hurt?
No.
Okay, and the skin moves on your ear. Do you feel me touch it?
Yeah.
Really?
Yeah.
Awesome. Okay, thank you.
Too cute. So one patient's perspective, obviously, some kids' ears do hurt when they sleep on it. So I'm not meaning to say that, they're hard and maybe so she's little and kids tend to adjust a little bit easier when they're younger and maybe older kids might notice more. I haven't really figured out that, but you can ask the patient panel if you're curious. So what do your patients look like when they're completely healed? And I decided to do this a little bit by the type of microtia, because as you go up in grade, your technical challenge gets a little bit harder. So here's a 15-year-old before and after surgery who had a grade 2, so the lower, 30, 40% was present, and she had a tragus already. And so I think it's important to see the ears close up, and then really important to see the ears far back in perspective, so it's really important to compare to the other side. Just seeing one side, it doesn't give you an accurate portrayal of how much the new ear is similar to the other side. So next would be a grade 3 microtia. This little guy from this summer, and here he is before and after with a close-up view. And here he is, comparison view. Then sometimes we get kids that have a protruding or prominent ear. So this is grade 3 on the one side and a little prominent on the other. And so, as you may have heard before, you don't really want to make too prominent ears that are going to draw attention to the ears, because we've decided the ideal ear isn't really noticed. So you do go a little bit low profile. So we pushed that back, not overly, but just enough, I guess, to make it a little less noticeable. And here's the comparison before and after, up close, and to the other side. And it's nice when I can to get a little video. So 360, you can't hide much. So here's this little guy turning around. Super cute. Like, who can't want to work with these kiddos? So this is certainly the hardest. We do have patients here today with grade 4 microtia. We call it anotia. They don't have an earlobe. In some cases, I can create an earlobe out of cartilage if I can borrow it from somewhere, or if they have it. Other times, like this patient, you just have to make it all out of the implant. So this patient has hemifacial and jaw issues, and he had an unusual hair growth pattern where he was sort of bald where he should have hair, and had hair where he should have not had hair. So that creates quite the challenge of how to make an ear. But here's his before and after. And then bilateral patients. This little girl from Ecuador who's 6 years old, and we've only done one surgery on each side. These pictures came from mom, so the sun is shining, so it's a little hard to see the ear, but here she is before and after. And there she is. The girls all want their ears pierced, and in almost all cases, we can pierce little girls' ears. So then one of the challenges, and I noticed a lot of patients here with hemifacial microsomia, is creating symmetry when you don't start with symmetry. The facial structures, jaw, soft tissues of the cheek, et cetera, are smaller when you have this condition. And here's an example of a little girl who had a, fairly moderate hemifacial microsomia. And there's a lot of tricks. It's taken me a decade to learn them, but there's a lot of really cool tricks of the eye to get, when you look at someone in the front view, to appear more symmetric than they kind of actually are. Also, some patients come to us with an unsatisfactory ear reconstruction, and this technique really does lend itself to a solution for those patients. This gentleman came from Saudi Arabia. He only had one operation, got back home, got back onto his life. So I'm just going to show a quickie before and afters to just show you that all these ears, they shouldn't look the same because you're matching something different. So this is one of our panel patients. So you can see his ear touch his ear. And another little girl with grade 3. This little boy had grade 2. This little girl had hemifacial. This little girl just had grade 3. Another grade 3. That's the theme, I guess, these little kids. This little boy had a really large ear. I did do a SuPor implant because the base allows me to make a bigger ear with SuPor, so I was happy with that. This little girl is the one who was snuggling her grandpa. This is another one of our panel patients, Miss Nia Bella, so you can talk to her. So why do ear reconstruction early? Is there an advantage? And we've studied this a little bit at Children's Hospital with a psychologist of mine, and we believe that these younger patients in that 3 to 5 year range seem to have less anxiety, seem to bounce back quicker with less pain. They, in time will have an earlier increase in their self-esteem and less memory of the whole process, and hopefully less exposure to teasing and bullying. And this last point is important to me. As you age, the flaps get thicker and the definition's better when they're thinner. So here's just an example of a young kid, maybe a 4 or 5 year old versus a teenager. And you can see already, just even with the flap, the definition is much greater in the younger child. So is there an ideal age for surgery? I used to not answer this question. I would say, no, there is no ideal age because you're the parent and it's whatever you want. But then I thought, I'm going to be selfish. From the surgeon's perspective, there kind of is an ideal age. Not to say that we can't do any age, because we can, but I have reasons for this age, so I might as well share them with you. 4 years old seems to be a really great age. I felt obligated that a paper came out, or an FDA warning, at the beginning of this year, and there are studies about the effects of general anesthesia on children and their brain development. And so they came out with a consensus statement, and it was basically that if you're going to do longer than a 3-hour surgery, you should wait until the kid is 4 years old. We feel like this would minimize risks, but we don't have proof. And a subsequent paper looking at the first 2 years after surgery, so in 2-year-olds, hasn't shown a significant difference in brain development. But why not err on the safer side? So I actually read this paper and it changed my practice. I decided to really, unless a patient really, really wants it and they read this and they say we're fine with it, I tend to prefer 4-year-olds. But there's another reason, and it's the flap will be a little bit bigger for me, and my new customized flap requires a little more tissue. But 4 or 5 is nice because you can complete everything before kindergarten. So how durable is a PIER? The temporoparietal fascial flap that sits on top of the implant actually is mobile over the implant. So you can see that the skin moves all over, even though the implant stays the same. And similarly, the ear can move and come off the head or move back, quite mobile because it's not fixed to the scalp and it doesn't hurt. Right, Brennan? All right. Everybody kind of wigs out at that, and I'm the only one that moves ears. Parents are like, no, I'm not touching that. But in terms of durability, all these ears will get hurt. It just will happen, just little kids. So this little guy was only 3 weeks out from surgery, and he got hit by a cart. And so, mom calls me worried this was bleeding. Super simple, because it's your own body's tissue. Put a little Band-Aid on there, put the skin edges together, and a week later, you're healed. This is this guy 3 months after his surgery, so you really can't tell where his injury occurred. Bug bites cause annoying problems and bumps, and they swell. They're very reactive, these ears, but then they settle down and they go back into place. So this is important because we don't think about it, but the ear is made with your child or your own tissue. It's yours forever. And as long as that tissue's healthy, that skin and flap can be used, and you can remove the implant that was placed, and if some newfangled implant occurs and it's better, we can still use all of your tissue. That's the part where you're addressing adapting to new technology. But of course there's risks to all of these surgeries. And these are the basic risks I go over with patients: exposure, infection, nerve injury, just to, not the whole face like an Atresia surgery, but just to the eyebrow, fracture of the implant, and loss of implant. So the exposure is a hole. You can see a little bit of the implant, and unfortunately, if that occurs, it requires surgery in almost all cases. But it's not a rejection. People use that term rejection, but the body's not rejecting it. It's a flap problem. It's not an implant problem. It is my belief, but I think it's really right. A rejection is an immune reaction, which you can't have one of those unless it's living tissue, like a kidney. So we know that this is a picture of how our tissue is biocompatible with the implant and it grows into it. So when you have this rejection idea, it's really what I would call an exposure or a hole. And as we said, it's mostly due to this flap. This is a super scary picture. This is an infection. They're really rare, but they can occur. I make people stay in LA because if you have this problem, I want access to you immediately. And as long as we get you on a medication, the proper medication that you need, you can usually just treat this with antibiotics and they get all better. So that's all that we did is medication. Fractures were an issue in the past. 2010, 2012 was sort of an era where we were having issues, and this is an example of an implant that got fractured and we have to go back to surgery, remove the fractured implant, put a new implant. But in about 2013, I redesigned the implant and I made that one-piece implant that I showed. And this is my son a couple years ago. He likes baseball.
Hi, I'm Jeff, Dr. Lewin's son. I love baseball, so today she wants me to show you how strong the SuPor ear implant is. Here.
Where is it? Oh, that's okay. I see it. All right. There it goes. Let's look at the damage. And it looks like it is completely intact. No damage at all. Not the most professional video, but gets the point across, I guess. I just kind of like it with the bird squawking in the background and all that. So loss of implant. So this is also a patient on our patient panel, and you can talk to her and her family. And it's sad in the sense that things did not go as we planned, even though initially her ear seemed to be doing really well. Ultimately, through sort of a series of, we don't really know why, we lost this implant for this little girl. And, you know, my hope is that we will come up with a solution for her. But this is my first implant loss in 5 years. So it happened very recently. But I do think, you know what? It was said earlier today, we're not perfect, and we really, really, really want to do our best for our patients. And it's hard on us when kids have issues we don't anticipate, but it's important for you in making decisions about what you want to do for your own children to understand, you know, the whole picture. So not a lot of people do this, and I wish more doctors did this. I just think you should be open and honest about your results. Every year I publish updated results, and actually my risks are here for 284 consecutive patients that have had surgery since beginning of 2013. And we don't include risks of patients that came to me that have had previous surgeries because they have a different scale. But for first-time kiddos, there's a risk of about 6.3% for exposure, a little over 2% for infection, and then kind of everything else is quite minimal in terms of nerves, bleeding, fractures. I've never injured a flap artery, and one complete loss of implant. So a couple quick questions to go through just to complete the picture for you guys. Can you combine the PIER with a bone-anchored hearing device? Yes, you can. You can do a magnet implant or a post implant for any of the vendors that you see out there, and we can do that without any scarring if we do it at the same time as the ear, as an example. And then what about combining Atresia repair with PIER? Yes and no. So the first combined surgery, doing both of those at the same time, was done in January 28. I was present at that surgery, although I was not the primary surgeon. And I did do several of these combined surgeries in this time period of 08 to 11. And I did not feel that my results were as good aesthetically, nor were the Atresia results as good. And there seemed to be more complications in these patients. And in the end, I just stopped doing it because I felt that the risks outweighed the benefits. And then I looked at it, and it's not that the surgery wasn't done well or properly or technically correct. It has to do with healing, and if you think about it, you have to make these canals really big because they're gonna close down. But if you put the implant at the same time that you do this big canal, you have no variability for positioning that implant. And when you can't control how kids heal, much as you would like them to heal right in the center, these are not my patients, but these are online images of these combined kids. And in essentially all cases, I can see that the canal isn't healing in the center of where that implant once was. You know, they close down and then it's hard to predict where they're gonna be. So I felt like it is better to do them separately when one is stable. And so which one would you do first? Well, you want the stable canal first, so once you've got that already closed down, I can ideally position this new implant to sit right where I want it for proper aeration of the canal, which is really important for a canal to be healthy. And then there are cases where we can do Atresia repair after PIER, but really myself and the Atresia surgeons do not like doing it that way if at all possible, because it just seems to put kids at a bigger risk and make the surgeries harder. So I'm going to tell you what's new in the practice, because a lot is new. We did move, and we have a new office, and we have a new OR, we have a new location, we have new staff, and we have a new technique that I want to introduce today. So we talked about how all ears aren't the same, and one of my, not frustrations, but things that I notice in spending all this time thinking about ears is I feel like I can do okay making kind of an ideal ear. So here's one of my kids from earlier this year, and a quote, ideal ear. And I think things look, pretty good at what I want to achieve. But when you saw all those different ears, not everything's going to match this. So I started thinking, what are my limitations with what I'm working with today? And the bowl, in my opinion, is small. It's limited. And the rims all look to me a little manufactured when our own rims change. As they're rounding the ear, they change. And then the base is full in the back. You don't get the depth that you want, and that's part of the current design. And then it can be really challenging to make a canal, like the appearance of a canal. So I have a Lewin ear implant by SuPor. Thank you so much, SuPor, because without you, we could not have designed this. But I tried to create a unique, customizable, one-piece porous polyethylene implant that I can now use to overcome those limitations. And this one-piece design, really nicely, you can't fracture it. It's created in one piece, so it's more of a subtractive sculpting than an additive soldering. The hand carving, which I do sterilely in the OR with a drill, gives a more realistic, handcrafted, I guess, appearance. It improves tissue integration because there's no more melting of the pores. All the pores are available for tissue integration. It has a larger bowl that I can better control the size of, and a new base design. This I'm kind of most excited about because it's allowing me to really, really focus on getting symmetry in patients that are asymmetric with their hemifacial microsomia. Okay, so our first patient was only 10 weeks ago, so bear with me. This is not a fully healed ear, but this is our first little guy, and I think, he's healing quite well, and I kind of want to show you that different angles than you're used to seeing of an ear that shows that we create what I call a pseudo canal, a fake canal that's got a shadow and a space, and it sort of makes you look like you have a canal when you don't. And then you can have a super deep space behind your ear, something that you can't get, to my knowledge, with any other technique. And then, your ear is not this sort of not two-dimensional, but uniform curvature. It's different. And so if you sculpt the rim to get thicker at the top where it should be, thinner at the bottom, and be sinusoidal, the way our ears are created, I feel like we can get a more realistic appearance. And then the control bowl, this little guy from, I think, 2016 or earlier this year, I'm super happy with his ear reconstruction. I think he looks good, and family's happy, but I did face these limitations. And so if you look really closely and you look at his bowl, they're not the same shape. The PIER bowl is much smaller. And so this 10-week-old little guy, this is his ear. And so if I'm comparing, I feel like I'm getting closer to my ideal for my patients. So I'm going to end with my opinion about ear reconstruction. And there's just a lot of strong opinions out there and a lot of choices and conflicting information. You guys just got to live with, you have a research project to get to the end of what you want to do. I think many of us would agree that if you don't have access to an experienced surgeon, maybe don't have surgery, because when somebody doesn't know what they're doing, the problem is so much worse than the original condition. But if you do have access, I think PIER is the best option, and I have reasons for it. So my reasons are rib cartilage has limitations that are not dependent on the surgeon. So they're technique dependent. You have to make that cartilage that thick or a certain level of thickness to get stability and strength. And there is a potential issue that it can warp if it's getting too thin. And there's a restricted skin envelope to deal with. And as you heard, the projection can be difficult. So I think that in terms of my goals, the PIER does create a more natural and realistic appearing ear in a single operation, and you can get pretty good symmetry to the other side. This young lady is 19 years after her original med-pore surgery. She came to me from another surgeon wasn't doing this 19 years ago, but we replaced her implant, and that flap tissue and skin was perfect. So we just took it out, put the new one in, and I believe with the new implant she'll be fine. Another panel patient, this is Sarah, you'll hear from very soon, 9 years after surgery. You can get a complete ear in 1 outpatient surgery. I would say now, wait till 4. And this little girl is amazing. She's smiling at you, having just transferred herself from the OR bed to her gurney, anesthesia machine behind her. I mean, that's how Dr. D wakes up patients. And all my pediatric guys do. They're amazing. But there obviously are disadvantages. We don't know the long-term outcome more than 25 years. If you get a hole, it is likely to require surgery. It's technically challenging. Not a lot of people know how to do the technique. Another panel patient from I think this is her first time seeing her ear 1 week out from surgery, and I think she's 3 weeks out, 2.5 weeks out now. So a fresh one. And I love this video.
I have 2 big ears. Thanks.
Oh.
I got so much ears.
Yes, you do.
This ear is awesome.
It does not get better than that. So thank you guys so much for your attention, and we'll go on to the rest of our program.